Good morning, everyone. My name is Robert Hamilton, co-founder and chief scientific officer of Neurophysiologic, and it's a pleasure to introduce the next installment of our webinar series with Dr. Andrei Alexandrov, who will be talking about the latest guidelines for transcranial ultrasonic monitoring today. It is my absolute pleasure to introduce Dr. Alexandrov, the Simmons Murphy professor and chairman at the Department of Neurology at the University of Tennessee Health Science Center in Memphis. Dr. Alexandrov started his work and training in Moscow, specializing in clinical neurology at the Institute of Neurology, and then moved on to the University of Toronto and the University of Texas with Dr. James Grotta. Dr. Alexandrov is world-renowned for his contributions in not only ultrasonic monitoring, but stroke, with hundreds of original papers, textbooks, case reports, review articles, editorials, and more. In addition to that, he serves as a director or board member on a number of medical societies, both past and present, including the Neuroimaging, or Society of Neuroimaging, and Society of Vascular Interventional Neurology, as well as many others. Finally, Dr. Alexandrov has participated in a number of clinical trials that have really reshaped stroke over the last 10 to 20 years, and it is our absolute pleasure to have him on the webinar today. I will be moderating, so any questions can be entered into the chat box, and we will get to those at the end of the presentation. And with that, I'll turn it over to Dr. Alexandrov. Thank you again for the presentation today.
Thank you, Dr. Hamilton. I hope you can all see my slides and the pointer. So these are my disclosures. I consult for Neurophysiologic, and I was past a member of these societies that are related to vascular and particularly ultrasound. So before we go into latest, let's talk in general, why monitor vessels, and I'm going to try to build the case. If you are not monitoring yet, why should you? And if you are monitoring, well, keep on doing great job. So transcranial Doppler allows us to detect brain embolism in real time. In fact, transcranial Doppler is the gold standard for that particular procedure. And not only we can detect, but we can also quantify and localize embolism and determine its significance. As related to the procedures that we do, both surgical, whether it's the heart or the neck vessels or intracranial, the important culprits that we can identify with ultrasound are hypoperfusion, hyperperfusion, and thrombosis. So in general, comment, if you're doing EEG monitoring, EEG is very sensitive to changes in cortical neuronal function, but it is non-specific to the mechanism by which neurons are malfunctioning. And the other thing that EEG is not sensitive, if you have a brainstem or thalamic problems, it may take a while for EEG to convert. So if you're doing just EEG, consider also TCD as a complementary monitoring modality, because not only you detect an event, you can also say, is this hyperperfusion, or thrombosis? And we're also going to be talking about how to assess perfusion changes, and particularly when clinical monitoring is limited. So transcranial Doppler as technology has evolved over the past, 40 years from a single gate, single channel spectral TCD display to then multi-depth display of the flow. And here it is, multi-gate Doppler. In this case, it's a power motion Doppler that shows you not only direction, but also intensity of the flow, and imaging, like transcranial color-coded duplex, where you can actually scan almost to the opposite side of the skull and kind of depicts with color branches of the circle of Willis and then navigate through it. However, regardless of technology that you are using, the end result is single gate waveform assessment. That's where you're getting your diagnostic information. And power motion display can further guide you and capture a bit more information than just single gate display. Whereas duplex scanning is rarely used for monitoring just because we don't have devices that would fix the monitoring the transcranial duplex transducer, which is essentially is an echo transducer. It's not designed for prolonged monitoring. So one of the highest yields of TCD monitoring is detection of microembolic signals. And obviously, every one of us who is doing monitoring and reading and interpreting has to know the definition for microembolic signals or high-intensity transient signals or hits. And these were published as a consensus statement in Stroke back in the 90s. We know that these microemboli, by definition, are random. Now they can arrive in cluster, but then the cluster should be random or related to manipulation. That's how you kind of make a causative assessment. If you manipulate the vessel and then you see emboli, that kind of puts it into temporary causation. They usually brief duration because they're micro. The definition, if this is a macroembolus that moves through the vessel, it moves slower and it often changes velocity. Then you're talking about macroembolization. But if it's just a chirp, pop, mowing sound and velocity didn't change, that's likely a microns size embolus. They have to be above the background, so you can, if you don't hear them, they don't exist because our ear discriminates loudness over 3 decibels. And in a single gate fast Fourier transform waveform, they appear primarily unidirectional. And every machine fails when a cluster arrives, when they're so too numerous that machine cannot recognize one from the other, or they overwhelm the machine, or they appear bidirectional. So that's where human observer, human interpreter of the monitoring system comes handy into play. And just to give you an idea how I interpret cluster of emboli, we did actually the study during bubble tests in a loop model, and we found out that to cover 1 cardiac cycle completely with microbubbles, equivalent of injection during right to left shunt testing, 1 cardiac cycle requires 100 microspheres to cover the entire cardiac cycle. And so when I see uncountable emboli, and it covers 1 cycle, I say it's 100, 2 cycles, 200, 3 cycles, and is 300. And that's how you can further grade multiple embolization. Please, if you have any questions, post them up through the chat, and Dr. Hamilton is going to let me know if there are questions. So to accomplish monitoring, you have to have a head frame, and I'm showing this head frame not to promote it because actually this product is no longer commercially available, but when you choose the equipment, you have to check the headbands that it comes with and see if you can fix the transducer reliably, steadily, so that if need be, patient can be intubated and you can still monitor with a small transcranial Doppler monitoring transducer. That's how tough these devices are. That's how good they can provide a grip. That is also very important to maintain steady angle of intercept and being able to monitor the most challenging situations, like, for example, acute stroke. So let me share you what we learned through early experience in monitoring carotid endarterectomy and then carotid stenting, which actually led to formulation of some of the guidelines that I will mention in just a couple. So pioneering work by late Merrill Spencer, as well as Bob Ackerstaff and Padayachi all over the globe, basically told us that if you monitor with TCD, you can detect major intraoperative, perioperative events, such as embolism, thrombosis, hyperperfusion, and hyperperfusion. And I built this graph for one of the editions of my textbook because I wanted to summarize kind of in a one generic presentation what can go wrong during carotid endarterectomy, how these waveforms will look like, and what criteria I'm applying to for diagnosis of these events. And so down bottom is the description of what's happening. These are basically the stages of carotid endarterectomy. I can give the whole hour lecturing about what can be detected during carotid endarterectomy just in its own lecture for an hour, but this would be just to show you as a resource that's available. And it's, again, as I said, it's based on cumulative work published by multiple groups. Picture worth 1,000 words, but how about we put picture with a little bit better context? So we took our knowledge gained in carotid endarterectomy, and when carotid stenting came about, some of the very first cases of carotid stenting, we were privileged to monitor because our interventionalists were saying, hey, we're venturing into the unknown. So how about you guys come up and tell us what's happening in the brain, because we want to learn the technique and make it safer and faster. And so here is an example of pre-stenting carotid angiogram. You can see that there is a severe stenosis. And when you inject the dye for diagnostic run, this is what you see on transcranial Doppler. So these are clusters of air bubbles that are in the dye load. In fact, when transcranial Doppler was applied first to monitor diagnostic angiograms, people realized, oh, with every shot, you're embolizing the brain. And at that time, they were using, I believe, Omnipac, and they would be shaking it before injecting. So a little interventional study kind of on a couple of cases. Well, if you are about to shake your contrast, why won't you let it sit after that for about 20 minutes on the shelf? So pre-shake it, but don't shake and inject. And that, leaving it on the shelf, reduced the number of these gaseous embolizations. That's just a little known fact. Then there are stages of procedures when you cross the lesion, and that's in an attempt to deploy distal protection device. You can actually go through a narrow residual lumen and can scrape something. So that scrapable something is also detectable. Fortunately, all these events did not change the velocity. So during that particular case, we said, well, if you crossed and if something is dislodged, at least it was not macro size. And then there was a deflation of the, inflation of the balloon. And in this particular case, this patient did not have a good circle of Willis. And so even with this high-grade stenosis, the complete cessation of flow through the artery produced a major decrease in velocity. And so I will go back to this equivalent of clamp on during carotid endarterectomy. And when you see velocity decrease going down to below 30% of pre-clamp with the steady angle of intercept, that velocity decrease predicts the drop in cerebral blood flow by 50%. So that is a significant event. And obviously, the longer you continue to manipulate the vessel without restoration of blood flow, the longer there would be duration of possible ischemia. And so interventionists here paid attention to it, deployed stent, then post-stent ballooning. That was one of the very first experiences way back early in 2000s. And after balloon was deflated, the velocity came back. You can see it. And so if you're learning the technique, you probably should consider a monitor so that you would appreciate the downstream effects of your manipulation. The other thing that we learned that distal protection device, even if it's deployed, it doesn't capture all emboli. Presumably, it doesn't capture small gaseous emboli, which is fine. but also probably some of the particulate emboli that can still occur in escape detection. So some of these early observations led us to write together guidelines between American Society of Neurophysiologic Monitoring and American Society of Neuroimaging. So that was kind of a joint labor here. And if you're looking for supportive materials to kind of launch your practice, decide what kind of materials you need in terms of TCD device, what are responsibilities, what do you do to provide that monitoring, you can use that. And particularly we talk about the value of monitoring as the assessment, not only for emboli detection, but also vasomotor activity, autoregulation. It all depends on the setting where you're publishing. And we also talk about identification of hyperperfusion and so forth. And I have more of these illustrations to come in. I then had a very interesting encounter with one of the sonographers who called me, and I think it was late 2000s, and said, I'm trying to submit a bill for a TCD, and one of major insurance carriers responded to me and said, we're not paying it because we still consider it experimental. And I'm like, oh my God, seriously, it's almost 25 years of TCD being around and we're still being considered experimental. So I said, what do they want? And he said, well, they actually asked me to fill out the following table. And so he sent it to me and I looked at it and I said, that's brilliant. They wanted to know what is the clinical indication of the test, what the test is supposed to show, and what are the expected outcomes. So that helped us to write the following guideline. Practice standards for transcranial Doppler ultrasound, clinical indications, and expected outcomes. So if you need guidelines to support you, this can also be used because we specifically say what are the expectations of monitoring of endovascular stenting, carotid endarterectomy, cardiac surgery, where you're detecting perioperative embolism, thrombosis, hypo and hyperperfusion. These are the mainstays. So even though we may not have a billing code for dedicated monitoring yet, although we should probably strive to get this code sooner than later, if you are working at an institution that values team approach and perhaps assigns RVUs for work like that, then you may be paid not through billing directly, but through hospital reimbursement of a multidisciplinary team that would provide something valuable as this. And then just about a couple of months ago, Alex Rozumovsky and the usual suspects wrote an update for ultrasonic monitoring. This is the latest guideline. And we specifically talk about the value that transcranial Doppler brings in producing better patient outcomes, decreased length of stay and the cost of hospitalization. So these are latest things that should be available from Journal of Neuroimaging for download. If you cannot download them for free, please contact us. We will find a way to get them to you. So back to some of the historic observations that actually helped us to further identify clinical situations where transcranial Doppler monitoring can be helpful. So I don't know if most of you on the call were practicing before mechanical thrombectomy, but if you did, you probably would remembered hours and hours and hours of long and frustrating cases when we tried to do intraarterial rescue with a kitchen sink of tools that were not optimal or were not really working or effective. And so at that time, if you look at time spent, from growing time to the actual reaching the clot and actually fighting the clot, there was a lot of time wasted because, well, this one didn't reach, this one didn't work, let's try something else, let's try something else. So there were a lot of what we call negotiations with the disease, and actual fight of time fighting the clot was relatively short and inefficient. And we were trying to understand how to improve those procedures, and we started to ask these questions. So, for example, if you sit intraluminally with a catheter that doesn't work for a long time, what happens with residual flow? Are you worsening ischemia? What's the optimal blood pressure for reperfusion? Oh, well, if you achieve TMI3 or TK3, is it with or without hyperemia? Sometimes, surprise, surprise, you take the patient for the CAT scan after intraarterial procedure, and there is air visible on the CAT scan. So where did this come from? Is there occlusion and either why they're bleeding after successful endovascular procedures? So these questions we had when we were trying to establish intraarterial therapy way before 2014. And so we monitored quite a substantial number of these procedures, trying to understand what's going on with this kitchen sink. And we published diagnostic criteria and yield of monitoring of intraarterial reperfusion procedures where transcranial Doppler was placed right during what was happening. And here's just a cumulative picture of everything that can be detected. I mean, you can hear the application of the Merci retriever. You see the consequences of roadmap or diagnostic runs. You can see the effect of applying penumbra suction device, all those things. And here is an example of occult continuous cerebral air embolization that endovascular person was not aware of. In fact, at that time, he was not even doing anything with the catheter. Catheter was in place. He was doing something else outside patient body. And we told him, there is air embolism going on right now. He said, from where? So these were all surprises. And this is the yield. So in these early days of endovascular procedures, the yield was nearly half of the procedures. We were seeing something not going right. And particular attention here, we had a high rate of reocclusion because these devices were not perfect. We found air embolism in 4% of cases, but also, and I'll come back to that towards the end of the talk, hyperperfusion was 12% after successful recanalization. So then all this technology was replaced by highly effective mechanical thrombectomy, thanks to advent of stent retrievers and later on large bore aspiration. And all of a sudden, the procedure time shrunk to the point that quick, let's go. And there is no time for monitoring. Thank God. So, but did we solve everything? So let me show you what questions we still remain. So now, if you started to practice recently, and now you have advantage of mechanical thrombectomy, what questions remain kind of unanswered? So we don't know yet what is the optimal blood pressure. The latest, I think, Enchanted MT trial that was presented at the World Stroke Congress answered an obvious thing that hypotension is not good for you. Other than that, it didn't provide any other clues. What's going on if you intubated the patient before mechanical thrombectomy? If you don't have good clinical exam, so how do you know if you sustain the flow that you have? Risk of symptomatic hemorrhage is not zero. And in fact, I'm going to show examples and what's happening with reocclusion and continuing embolization. These are the questions that we can answer with monitoring. So let me just show you. This is a kind of a these days garden variety case where a 60-year-old man with NIH stroke scale score of 17, left MCA syndrome, aspects of 9, gets TPA within 3 hours and transferred drip and ship to the comprehensive stroke center, and on arrival, there is persisting M1 occlusion. So the patient is taken to thrombectomy, and here's the M1 occlusion, and with one pass, it's TK3. So that's routine these days. No surprises, high five. We have an effective therapy to remove these clots. Then what happens to the patient? Patient is being managed according to the guidelines, where blood pressure needs to be kept below 180 over 105. And he is running like 170, little over 180 for a few hours. And then in the intensive care unit, the nurse notices decreasing level of consciousness. A stat CT is called. And by now, I hope a lot of you have seen cases like that. If you haven't, that means you haven't practiced enough mechanical thrombectomy yet. You look at this and like, oh my God, what is this? Is this a bleed? Well, there is some blood products for sure. Some of that is contrast, but distribution is such as that is mostly follows subarachnoid space. There may be some intracerebral component, but we've all seen this. And unfortunately, something like that, if it occurs after mechanical thrombectomy, doesn't lead to good outcomes. So despite that brilliant quick reperfusion, a modified Rankin score is still 4 at 3 months. So what's happening in that case? And let me share with you what we learned from TCD monitoring of IV TPA treatments before we even had thrombectomy. So blood pressure management-wise is very permissive, and parameters that we have do not exceed 185 over 110 before you start reperfusion, and do not exceed 180 over 105 for 24 hours post-reperfusion. That's too generous. And what we know is that the higher pre-treatment systolic blood pressure, the less chance of recanalization. And if you violate the protocols for these higher blood pressure thresholds, these violations of blood pressure management lead to increased risk of intracerebral hemorrhage. So here is the first case of M1 MCA occlusion that was treated with IV TPA only, that led to successful recanalization that we documented in the literature. And here is the systolic spikes at the beginning. This is of the treatment. This is the beginning of recanalization, and this is a quick, complete recanalization. So we were so happy to see it that we actually sent it to Circulation, and they put it on the cover of Circulation. Fortunately, the reviewers didn't ask what happened to the patient. So this is particulars of this particular patient. So he developed full right MCA syndrome, NIH stroke scale score of 15. He was treated towards the end of TPA window, and it took about additional 36 minutes between this frame and this frame to start recanalization. And then from this frame to this frame, just a couple of minutes where TPA finally got to and through the clot and helped break up fibrin strands, and poof, complete recanalization. What we didn't pay attention at that time was that he was 75 years old, and 75-year-old man recanalized to the mean flow velocity of 75 centimeters per second. That was a little too generous. We were not concerned about this at that time, partly because his blood pressures were under control, or so we thought, because we kept him below 180 over 105. And unfortunately, 2 hours later, we got first of all, he did not recover from this recanalization. There was no immediate on the table kind of dramatic recovery response. There was none. And 2 hours later, he developed GCS of 3, and that was a massive fatal hemorrhage. So what is it? This was predictive of this. So we described it actually in that paper of monitoring intraarterial procedures as hyperemic reperfusion. Okay, and it's analogous to cerebral hyperperfusion syndrome that was described way back in early days of carotid endarterectomy, particularly when transcranial Doppler started to be applied to monitor those patients in the 80s in the past century. And if a surgeon was operating on carotid artery under local anesthesia, that actually allows you to clinically detect that hyperperfusion syndrome. So what is it? When you release the cross clamp and you restore the blood flow quickly to the brain that was maximally dilated and unable to autoregulate, this incoming rushing blood overwhelms the autoregulation and leads to headache. The patients would say, "Oh, my head hurts on one side." That can then lead to even seizures, and then you can see subarachnoid hemorrhage and blood extravasation, like we saw in our case after mechanical thrombectomy. We think that this process contributes to hemorrhagic transformation, symptomatic ICH, progression of edema, neurological decline, and even seizures after stroke. In fact, I'm gonna just say, ask that question: how many of us are being consulted on seizures after stroke, and how many of us will check with transcranial Doppler if this patient has delayed reperfusion in a subacute phase with hyperemic component that actually leads to seizures? The answer is probably none. So something to consider, and it's directly detectable by TCD when you detect normal or elevated mean flow velocity or low resistance pattern, particularly if the PI is less than the normal side. That's when you know that this patient's vessels are not limiting the incoming flow. So we published it in 2010. We presented this at one of ISCs, I want to say around maybe 2017, 2018, so kind of raising the awareness that these things are coming. And an Austrian group, I believe from Graz, followed on this. And they just published this, I think, in September issue of JNAS, Journal of Neurointerventional Surgery. This is a very elegant case. They prospectively set out to determine can they find with transcranial duplex just at least one examination after MT, or maybe with a serial examinations, what's going on with these reperfusions. And here's an example of pre-treatment, post-treatment, looks great. Normal side, looks great. Affected side, velocity is way above unaffected side. And as a result, you have hyperemic change on MRI, you have vasogenic edema, and you have hemorrhagic transformation. So how often do you think this occurs after modern day mechanical thrombectomy? So before, we found it in only 12% of cases, but our tools were ineffective. So TK3 was not that common. Nowadays, TK3 is more common and TK2C is more common, right? So this is their study. And as you can see here, they focused on, they excluded tandem lesions because that's a little bit more difficult to interpret. But they just looked at essentially proximal MCA occlusions, and particularly the ones that achieved TK2B to 3. And I'm going to cut to the chase here and put the number. 75 out of 226 subjects, 33%, full third, had hyperperfusion on TCD. And TCD findings of this elevated velocity predicted hyperemic changes in vasogenic edema and possibility of hemorrhagic transformation with accuracy exceeding over 80%, particularly for hyperemic component on blood flow study. And they also noticed that about half of patients in that study had actually hemorrhagic transformations on MRI. It is expected, but still, this number can probably be minimized by controlling this hyperemic reperfusion. Here's their specific findings. So this is post-reperfusion MRI. So this is TCD positive patients, TCD negative patients. And you can see here, 86% of TCD positive patients had hyperperfusion evidence on MRI. And any ICH on MRI, 52%. I think this is pretty convincing data that we can detect certain events that can remain clinically silent, but potentially can lead to complications or tie up our options for secondary stroke prevention. So this is kind of one of suggestions that I have to the team, and this is how I use this information, and it's a personal opinion until more randomized controlled trials are completed in terms of telling us where to keep blood pressure during mechanical thrombectomy, and particularly after mechanical thrombectomy, and they're ongoing. But until such information is available, outcomes after mechanical thrombectomy are not one size fits all. So, for example, if one achieves TK3 and dramatic recovery on the table, to me, that just proved that the patient has absolutely salvageable brain, intervention was on time, and this patient does not need this permissive blood pressure up to 180/105. Absolutely no need. To me, if I haven't started blood pressure drip, medicine drip before thrombectomy, this is the patient I would like to keep normotensive, not hypotensive, like it was presented, but just below 140/80. Don't go below 120, just bring them below 140/80, and hopefully that will protect the brain from the hyperemic component of that reperfusion. If you had TK3 and no immediate neurological improvement, or TK2 with some neurological improvement, there is something interesting here. So TK3, no neurological improvement, you either too late with reperfusion, or microcirculatory flow is compromised. And so you might consider kind of give it a little bit of a push to overcome that no reflow phenomenon. And I'm okay with kind of moderate elevation of blood pressure, but not exceeding 160/90. TK2 and neurological improvement tells you two things. Brain is salvageable, but the vessel that supplies the brain, patency is not completely normal yet. And so reocclusion may occur. Worsening of the residual flow may occur. And so in that case, keeping blood pressure a little bit up is probably, at least theoretically, makes sense to maintain that TK2 through the vessel and to deliver some goods to the brain, but not again too high, because reperfusion will occur eventually. Okay, and that eventually is very important. So what if 6 passes, nothing, or occlusion, recanalization, reocclusion, recanalization, reocclusion, final result, no recanalization, reocclusion. In that case, I would still favor not permissive hypertension going way up, but just stay below 160/90. So why is that? Well, in our studies of monitoring recanalization, lack of recanalization at the end of treatment emerged as a risk factor for symptomatic hemorrhage. And you can say, well, that's counterintuitive, right? So hemorrhage may be coming if you open too quick, too fast, get hyperemia and bleed. Well, yeah, that can happen, but that you can detect and that you can control the blood pressure. We did the studies at the centers that watch blood pressures like a hawk. And we found out that even if you watch blood pressure by guidelines below 180/100, like a hawk, lack of recanalization at the end of the treatment results in delayed hemorrhage. Why? Because if the patient, most patients will recanalize eventually, either with our help or their own, and that recanalization can come many hours or even 1 or 2 days after the initial treatment. By that time, ischemic stroke is complete, at least the core, and when you recanalize that vessel, particularly completely, at a higher blood pressures that this brain can handle, that's where the bleeding can occur. And so to me, leaving a patient with occluded vessel with blood pressures running high can lead to that hemorrhage. So I would prefer to control it. Now, having said that, is there any situation when I would consider permissive hypertension? Well, yeah, if I challenge the patient and if I see that there is a response, neurological improvement response to either higher blood pressures or to simply positioning of the patient. Like we don't keep them 30 degrees up for the first 24 hours, it's flat. And if there is persistent occlusion, I may try Trendelenburg and see if that simple positioning causes neurological improvement. And if there is, that means this patient needs higher blood pressure to maintain collaterals with persisting occlusion. But without that evidence, I would still stick to the kind of moderate control. And again, it's personal opinion. The only thing that I'm going to show on this slide that is data-driven is this statement. Whatever blood pressure control you choose, you need to achieve it and achieve a strict control. You cannot have this. You cannot have too much variability in blood pressure because it has been shown as really damaging across multiple studies and with reperfusion therapies, whether it's IVTPA, whether it's bridging, whether it's primary MT. So kind of in conclusion, in modern days, when we now have highly effective mechanical thrombectomy, these are the questions that you can answer with monitoring, and particularly in the intensive care unit in the middle of the night where everyone is gone and, God forbid, patient is intubated. So is the chosen blood pressure tolerated? Because if the blood pressure is higher than the patient needs, you're going to see high velocities and low PIs, and that's invitation for hyperemic reperfusion injury. If achieved TICI was less than 3, are you maintaining the residual flow? Is there reocclusion? And if it's a reocclusion, and if you repeat imaging, and if brain imaging still looks favorable, maybe you can repeat thrombectomy and secure that vessel. Intubated patients, that's the only way kind of to substitute your neurological exam with at least evidence that you're maintaining blood flow. Transcranial Doppler can detect directly proximal reocclusion and indirectly persistence of the branch occlusion or branch reembolization. And again, we've even started this lecture with it. One of the cornerstones that goes against all that goes across all the guidelines, and one of the mainstays what TCD brings to the table. You can detect continuing embolization in real time and point to the source of embolization, particularly in a stroke patient, particularly in a fluctuating stroke patient, or in a patient whom you are assessing post-operative or a variety of other revascularization procedures and surgeries. So I'm going to stop here, and I think we have enough time for questions. And so please go ahead and ask them either through chat or if Robert can see you raising hand and kind of go live if the question is too wordy to type.
Yeah, thank you. Thank you very much. So we have our first question come in. How much gas emboli can be tolerated without any symptoms?
That's a great question. So little air bubble in IV line going to the vein that it's damaging its old tail. Apparently, you need to inject as a bolus over 19 cc's of air as a bolus to even cause some cardiac dysfunction. So that's what we know about the heart. About the brain, the situation is a little bit more difficult because we do a lot of bubble tests for right to left shunts, and we are telling basically people that it is a safe procedure. There is a rare event of fainting, headache, vision changes. There was only one self-reported stroke-like case in the literature after thousands and thousands, if not hundreds of thousands of these tests done. So we don't have clinical tools to even detect the impact of a 1 cc of air dispersed in a 9cc syringe. So that part, obviously, we present as safe to the patients. And I always refer that if you don't believe TCD data, well, look at how many bubbles cardiologists inject. They inject a lot more bubbles than we do. Where I would strongly look and see if embolization is dangerous is this. Let me just go back real quick here. So this continuous gaseous embolization was occurring when the catheter was inserted through transfemoral approach, and somehow bubbles were traveling, air was traveling through the catheter, along the catheter, whatever, but it was lodging in the brain in the quantities very selectively. And you probably saw some post-catheter angiography, a CAT scan that showed this air embolization. We also had big air embolization during exchange of the catheters. Patient was treated for carotid T occlusion, and we detected that in real time, and that was really kind of massive number of bubbles that were uncountable. When I detect something like that, that's when I would start thinking about consequence of at least isolated cerebral air embolism and consider probably a hyperbaric chamber.
Great. We have a two-part question here related. So the first is there recognized criteria or a threshold for identifying hyperemia with TCD after reperfusion procedure?
Yeah. So, hyperperfusion increased mean flow velocity to 1.5 times over affected comolgus contralateral arterial segment. That came definition from carotid endarterectomy. That's the very specific definition that Merrill Spencer derived, and we found that with older technologies, that definition yield was 12%. In the study by Niesel out of Graz, they used a little bit more kind of inclusive definition by saying that velocity just needs to be, I believe, just more higher than the other side or equal, but with a lower pulsatility. So with that definition, the yield is 33%, but I don't think it's the definition. I think it's the speed of reperfusion, because a mechanical thrombectomy is highly effective. It's not that kitchen sink that we saw earlier. With one pass, you're restoring natural blood flow to the area that could have been ischemic for a while. And so for me, this finding of hyperemic reperfusion is no surprise at all. And in fact, it gives us a great intervention target to improve mechanical thrombectomy even more.
Yeah, and a quick follow-up to that would be then based on those thresholds, do you have any experience in manipulating blood pressure post-mechanical thrombectomy to try to optimize BP?
Yep, that's the one. So TK3, patient is starting to move and talk on the table. Great. I go normal tension. Normal tension. If I haven't controlled blood pressure before mechanical thrombectomy, I will definitely start monitoring it now. And that patient is going to go on a nicardipine drip or clevedipine, whatever you have. And I would keep this patient normotensive if there was such an excellent response to reperfusion. And then I would allow a little bit higher blood pressures for incomplete recanalizations or incomplete recoveries. But I would avoid allowing it to go up to 180 over 105. These are too generous, too much. Brain doesn't need that.
Do you have suggestions on time duration of monitoring? Is this a spot check once the patients are settled after the thrombectomy? Is it on the table? Thoughts on how to implement practically from the monitoring side?
So I believe in this study, that was at least a spot check at the very least. And even a spot check is predictive of what you're going to see on MRI. I think the value of this is early after mechanical thrombectomy. Because when and let's be practical. So you're done with thrombectomy, your endovascular person says, here's the blood pressure. I believe most are still applying TPA blood pressure criteria, which is not designed for that setting at all. And the patient goes to the neurointensive care unit. The ideal time to check is when neurointensive team is getting the patient, does exam, and checks and compares one MCA to the other MCA for the highest velocities. And if you see that the patient recovered to above what's the contralateral non-affected side is, that is the patient at risk of hyperemic reperfusion. So at least that one spot check is already better than nothing. But then if you engage into, okay, let's continue to monitor and make sure that blood pressure chosen is being tolerated so that the patient is not developing hyperemic reperfusion, extending monitoring, if you have monitoring gear, you can do emboli detection, you can answer other things, particularly if the patient is still neurologically fluctuating. That's in whom I would extend monitoring from just one spot check.
That makes sense. I know today's presentation was really focused. I know there could be a number of different areas, and one of my questions was, outside of carotid endarterectomy and post mechanical thrombectomy, just quickly, are there other areas or procedures that you feel have high benefit from either interprocedural monitoring or post-procedural monitoring that could benefit from more constant hemodynamic monitoring?
Yeah, so it depends on your surgeons and your interventionists. If they are performing procedures that are high risk of stroke, they might be interested to work with you and get the monitoring done. Quite often it's the limitation that no monitoring people are available, no expertise is available, or yeah, we have a sonographer, but he or she does not have experience in the OR because there are certain things that you need to do there differently, and it's a different commitment from what you would normally do. But to me, there are multiple procedures that are high risk right now. People are reporting TCD findings in what TEVAR, TECAR, then ECMOs. I mean, there are all sorts of high risk procedures that if you have in-house expertise, you at least need to let those folks know that you may be available and see how it goes. Our own experience with monitoring carotid endarterectomy, it only worked because we had surgeons who were inquisitive and they wanted to make their product better. And so we had a meeting that was in one of my previous institutions. They were high volume surgical case. And I said, well, we can detect the following things for you. Embolism, hyperperfusion, thrombosis. We set kind of the rules, how we're gonna monitor and disclose that during the procedure and what the surgical team will do in response to these findings. So you got to troubleshoot that ahead of time if you're going to engage into building a good monitoring program for your surgeons.
Great, thank you. Another question came in about when managing blood pressure, depending on the Tiki score post-mechanical thrombectomy, is there any impact on cerebral autoregulation? Is cerebral autoregulation intact in these patients? How is that assessed, or how is that the role of cerebral autoregulation used kind of in the management of these patients?
Yeah. So the clinical trials that would be telling us how to kind of tailor-made blood pressure are still on the way. We still don't have individualized blood pressure control. If your center If your endovascular folks are kind of already tailoring their blood pressures to TICI, final TICI, that's great. I think it will be just the kind of difference between 150 and 160 at the end of the day, where to bring them down to, but it's great. So how do you assess for autoregulation or not? So this is graphic representation of what Merrill Spencer found in his early cases of carotid endarterectomy. So if you had pre-revascularization, a blunted flow signal, and then you had interruption of blood flow, and then you release the blood flow, and blood flow goes up into the area that was starved, even for minutes, hours, days, or years, you're going to see that overshoot of velocity. It invariably goes up because the field is dilated and it's kind of hungry for the blood. And if you have good autoregulation, the brain will quickly downregulate this velocity to nearly normal values. So you will see that brain clamping on the blood flow. But to see it in real time, you really need to be there when recanalization occurs. And since we are not monitoring mechanical thrombectomies, like if you can do carotid endarterectomy, you would not be able to see that autoregulatory response, initial autoregulatory response. However, we know that patients in whom failure to autoregulate persists, they have this waveform. So the waveform is higher than normal, and diastolic component is higher than the normal side, whatever normal is for that patient. And in the initial studies of carotid endarterectomy and reperfusion, they've seen hyperemic flow signals in a lot of patients, particularly the ones that were really dependent on that incoming flow, and those who had like trapped MCAs. And in those, these changes are the most pronounced. Hyperemic response was generally overcome by the brain autoregulation in a matter of 1 to 2 minutes. If that hyperemic waveform persisted for over 2 minutes, that's the one who is heading into hyperemia. And so even though you may not have luxury of detecting autoregulatory response right at reperfusion, by the time the patient comes to the neurointensive care unit, if the velocity persists as high, or that is hyperemia. That is failure to autoregulate.
So I want to be conscious of time. We have a few more questions. How relevant is TCD application in detecting DCI and distal microthrombi after SAH, in your opinion?
Ooh, that is a very, very, very good question, because it has been coming on and on and on. So the original report, I believe, was by Dave Newell, who found like 15% of patients in whom aneurysm was fixed or partially fixed still had emboli distal to it. So the question is, with all the new ways of fixing aneurysms, is there incomplete healing to distal vasculature embolization? The caveat here that I want to bring up is that we may be over-diagnosing microembolic signals in patients with subarachnoid hemorrhage for 2 reasons. One is if they have right to left shunt at rest, every time someone injects flushes saline, they can produce microembolic signals that have nothing to do with anything. And since shunts are common, I would make sure that there is no shunt if I want to do emboli detection study. The second one, we are diagnosing a lot of emboli who are not related to anything. These are DEFINITY microspheres that can be detected hours and even a day or more after echo test, if echo was done with DEFINITY, because the DEFINITY bubbles live in that port through which they were injected, and they re-enter the system. So you may have false positive diagnosis of emboli. So just be careful. If you're going to monitor subarachnoid hemorrhage, make sure no shunt, no one flushes saline syringes, and that echo, if it was done, replace the port.
And the last question here in the last minute we have, in terms of the acoustic window, how often do you get it in these procedures? And are there any patients that you would not use TCD on for monitoring?
All right, so great question. So true no window should be less than 5%. That's kind of, you cannot find the signals. Part of the reason, particularly surgical patients tend to be on the younger side if you're doing surgeries. If you're doing patients who truly have no window, but you still need to get some diagnostic information, remember that you can briefly assess the internal carotid artery siphon through the orbit. And that's almost always present. Or you still have access to the basal artery. You may not get as good information as you do through MCAs, but at least some information you can obtain.
Great. With that, we've ended our hour. I just wanted to thank Dr. Alexandrov again for his time today on a very, very interesting presentation, and hopefully the use of TCD monitoring can continue to extend the benefits of mechanical thrombectomy that we've all seen over the last few years. So thank you again for your time today.
All right.
And stay safe down there in Orlando.
Yeah, Nicole is just trained at the moment, so we don't have any bad reports, thank God. So, all right, see some of you next week at SVIN. We're going to talk more about this.
Thank you.